have an opportunity to discuss and ask questions about some ENT cases and some common COVID symptoms which we know we're all grappling with, which is anosmia. In terms of etiquette, we all know the drill. If we can stay on mute, unless you're unmuting to ask a question or to participate in conversation. Would encourage you to use the chat function and put in any questions, and Anisha is expert at bringing up the questions. And if there are questions that we don't get a chance to answer today, then we will try to answer them and get back to you. We are thrilled to have, as well as the ENT input from Mr. Batt, to have diabetes specialist nurse Soraya Kolil and Orna Hillman, the diabetes specialist podiatrist, both from CLCH community clinics, for a service update. Before I hand over to Anush, I really want to say a lovely congratulations to Anisha. I don't think she knows I'm about to say this, but she has just been appointed formally to a couple of roles. One is the training program director for the GP specialty program, and the other is as clinical lead for the training hub. So we've known over the last few weeks and months she's been instrumental in helping to get these organised, so that bodes incredibly well for the future, and want to say congratulations really and well done on your new appointments. Also, as I mentioned about summer break, just wants to do just a little bit of just an update. Into the bulletin we have got some public health data, which I know lots of you have wanted, local data, and Tamara Juretic, who's our public health director of public health in Barnet, is submitting the weekly dashboards, which I think would be tremendously useful. She also gave a summary, and it came out on Friday, and there's a bug in the system that in my sending it over to the comms team ended up changing one of the words that was really crucial, and then when we sent out a correction yesterday, it's happened again. So it talks about we're going to send some more comms out today and on Friday, so deep apologies for anybody who's been confused by it, but it was really to say that the restrictions that were going to be lifted on the 1st of August, the majority of them are not being lifted till the 15th, but actually for the shielded group that has been lifted. So that's contrary to what's said, and there is some bug in the system that's changed a T to a W, so it's completely changed the words, meaning going from now to not. So my apologies about that. There's some kind of bug in the system, but we're going to send some more comms out, so apologies if that's been confusing. Many thanks, and lovely to see now we've got over 40 people. I'm going to hand over to Anuj for the Federation update.
Hi Charlotte, I think I'm going to give the update. It's Michael.
Oh, hi Michael, apologies. Hi, nice to see you. I guess Anuj is on holiday.
Yes,
break. Okay, hi Michael, hand over to you, thanks.
And apologies, I'm having to come in on my phone because I couldn't do it through my computer, so hopefully everyone can hear me. Yeah, if we could go to the next slide, please. The details of EAS remain the same. The one change which we've instigated is now that people can book weekend slots from the Monday rather than the Thursday, and that started this Monday. And for the AAC, there are changes. There's going to be a NCL-wide approach. We thought that would be instigated on the 10th of August. However, we've been asked to keep the local process going for another week. The new process has been developed in a collaboration of all the federations across NCL. The requirements will probably be around a single triage process and probably 2 sites from which home visiting will be based. But there'll be more details of that coming out later. We can move to the next slide. Just a quick update for those practices that use our EHS service. They can be now booked 2 weeks in advance. We had requests from practices, so we put that in place. I think there's been many discussions about the anticoagulation service. It's still running and we've still got capacity to take on more patients. And the last slide, please. Yeah, it's just the activity. We went slightly above plan with the sessions that we put on in July, so there'll be a small reduction in sessions in August just to bring us back in line with plan. We know that the number of GPs ask about that, so there'll be slightly less sessions than in July and August, but that links in with tend to have lower activity there, and hopefully we'll be back in line with plan. So I'll end there. I don't know if anyone's any questions.
Thanks so much, Michael. If there are any questions, if you want to put them on the chat or raise any hands, give you a few seconds for that. Okay, if you think of any later, then put them in the chat and we'll try to answer them in due course. So really lovely to welcome Soraya and Orna, who are going to update us on the CLCH community update for diabetes services. So many thanks to you both.
And Soraya, just to say, Soraya, that no rush with your talks. I think Yogesh Bhatt, our ENT consultant, is having a bit of trouble logging in.
Okay.
Have more time than we originally thought.
Okay, that's great. Yes, so thank you for inviting me. Just to give you an update on the community diabetes service. Sorry, can I have the next slide, please? So we've had an MDT service since 2016, where we have the role-free consultant, Dr. Sarah Ali. She normally joins us every Tuesdays and Wednesdays, and we do MDT clinics with her. That was pre-COVID. During COVID time, Dr. Ali was redeployed to the ward, but it's been about a month ago that she started doing her telephone consultation. She is away on leave at the moment, but she should be back by end of September. And in between, we have Dr. Rosantal that's helping us in the community if we've got any clinical queries. So our team consists of equivalent of 5.6 diabetes nurses that include myself. We also have equivalent of 2 whole-time of diabetes dietitians, and we have Orna as well, and she's 0.5 with us, so 2.5 days with us. And we've got admin to help the service running as well. So that's us. It's a small team, but I think we're doing quite well. So what we've been doing is, sorry, if I do the referral criteria first, and then I can go into the service update. So with the inclusion referral criteria, that's for type 2s. It's not really for type 1 unless it's a type 1 who is housebound, and the secondary care team will not be coming out to visit them. Then we would accept those referrals. Otherwise, they generally tend to be seen in secondary care. So any patients with type 2 diabetes being discharged from the hospital, they were an inpatient, started on insulin, or just need some monitoring before they discharge back to the primary care, they will be referred to us. That will be a direct referral from the hospital team to us. People who have persistent hyperglycemia on maximum oral therapies. I know quite a few practices already doing their GLP-1 as well, so that could be persistent hyperglycemia, maximum oral plus GLP-1. Otherwise, we accept referral just to initiate GLP-1 therapy. Urgent clinic, they tend to get seen within 2 weeks. So that would be patients with osmotic symptoms, recurrent hypos, having to go to hospital, or persistent high blood glucose level above 16 and not feeling great. Any adverse reaction to their diabetes medication and needs to be reviewed. Poor glycemic control due to steroids and need something immediately to control the blood glucose levels. Like I said, also any GLP-1, insulin start therapy, then they come to us if your practice is not doing it. We also have patient education program. Now, this we've got some location which we are not doing at the moment because of COVID time. So it's been about we've done about 6 sessions now, online group sessions, where we invite 9 patients per group, because that's the number of patients we can see in a group at the moment. We use the BlueJeans app. So this, I understand, is going to be upgraded so we can have more patients in the group. So far, we've had very good feedback. We are able to give them most of the information that they need, that we would be doing in a face-to-face. And also, after this online session, we would give them a call to get some feedback from them, as well as opportunity to ask any question that they may have had and haven't asked us online. So that's going quite well. If your patient just need dietetic advice, then you can refer them, not necessarily just for the diabetes nurses. If they come to an MDT service, if we feel that they need to, they could benefit from dietetic input, we will offer them that option as well. So that's the inclusion referral criteria. And the next slide is our service update. So from next week, we can start seeing patients in clinic, both at Edgware and Finchley. The sites should be ready by then. But for the emergency clinic, we've always been seeing urgent patients, even COVID, at the beginning of COVID times. And generally it's just 2 patients per week we're seeing, just to start on injectables. Some people are, because they are shielding, they don't want to come to clinic, or we've been able to optimize their other therapies and not needing some insulin right at that time. So that's for the urgent one. We see them within 2 weeks. And if the patient doesn't actually need to be seen, you can always ring the office line. So since COVID, what we've done is when you ring the office line, it directly goes to a clinician. It doesn't even go to the office, because not everybody is working on site. Some of us are working at home sometimes. So you get to speak to a clinician if you've got any queries, whether to refer the patients to the urgent clinics or not, or what other options that you can do for the patient. And we're offering virtual support at the moment for any patients that's been discharged from hospital. And I think that's quite ideal, because they're probably weak, not able to come, and we can do that. We also starting one-to-one video consultations for our patients, so that will also help. With the for the persistent hyperglycemia, we are seeing them within 3 weeks, although now we're getting some more GP referrals coming in, so that would be probably 3 to 4 weeks. We are seeing routine patients virtually. Injectables, yes, we will offer them. Say if I've got a patient hard of hearing, but not necessarily urgent, needs to be seen within 2 weeks, but they do want to see someone face to face. If they don't have any symptoms, then we would accept to see them in clinics. Dietetic individual assessment, that's again being done by calls, phone calls or video calls. Patient education sessions, we don't know when we're going to start face-to-face, but we're doing the online. And podiatry service owner is going to present her information on that. So generally, I think we're doing quite well. All our pre-booked patients that we've had on in our clinics, none of them were cancelled. We still managed to call them, and we're just re-auditing all our lists now to make sure that everybody has got a follow-up, so that we haven't missed anybody. And hopefully with the blood testing service opening more, we will be able to do more screening as well. So that's my update. Do you have any questions for me?
Thanks so much, Soraya. That was really helpful to hear about the CLCH service. There are 2 questions for you in the chat. So the first one is from Vidya, who says, you said patients to be seen with osmotic symptoms within 2 weeks. Is this safe?
So generally that's the urgent one. It depends how much information you put on the referral form. We do try to inform call the patients within a day or two, but this is part of the service spec. The agreement is within 2 weeks we need to see the patient. But if you put the information that your patient is very lethargic, very weak, not feeling well, and so forth, that will give us even more information to expedite and do the consultation quicker.
Brilliant. Thanks, Maria. And then Sanjeev has said, does the diabetic service provide an advice line for GPs, pharmacists and nurses?
So we haven't had a lot of GPs or practice nurses calling us, so we are coping with that. And yes, we are inviting you, any of you who wants to call us, because at the moment, you know, when you ring the office line, it's going straight to a clinician, so we should be able to help you on that. We'll be gladly helping you on that. The other thing that pre-COVID, we were working with the transformation lead Enrico to start planning how, you know, working in PCN. So us, the CLCH team, coming out and working with the PCN team. This hasn't happened obviously because of the COVID times, but one of the practice Temple Fortune Health Centre, what I'm going to do is we're going to do like a virtual clinic with the GPs there. So at the same time, I'll be learning how to, you know, work the EMIS, etc. So I think that would be good.
Brilliant. Yeah. And so if you wouldn't mind just posting the number to ring in the chat function, that would be really helpful.
Okay.
Or email, I can do that.
Yeah. And if you do forget, then it is on the referral letter. You've got the phone number there, but I'll give it to you now.
Okay. Thanks, Mariah. I know we're going to hand over to Orna in a second just to hear about the podiatry service. Dave, there's a comment from David Rubin for the CCG and Federation about the flu season. David, if it's okay with you, I will leave that to the end, if that's okay, because I've just noticed that your guest, our ENT consultant, has managed to sign in. So I know he was having problems with his device, so we'll leave that to the end if that's okay. Should we pass over to Orna now, Soraya?
Thank you. Thank you.
Brilliant. Thanks, Soraya. Thanks so much. Hi, Orna. Orna, are you there? Okay.
Can you hear me?
Oh, yes, we can hear you now. Thanks, Orna.
Sorry, I'll try and be quick. So basically what's been happening up to now is we've been seeing mainly the tier 3 patients. So we're doing them as home visits, and they're only seen according to need. I think we've only seen about 3/4 of the patients because a lot of people have declined anyone coming to their houses due to COVID. We have had one clinic running throughout, and that's nail surgery. Basically, now we're getting a lot more people coming in who have who are becoming more tier 3 because they've been left so long and the position has changed. Okay, now we've got this. This is at the end of the waiting list of the referral form, and everything is practically the same apart from the pathway. So like everybody else, we are doing a telephone assessment first. So if you think the IAP is normally 46 days, we're seeing most people in a couple of weeks. So we're doing quite well on that. And any low risk patient is basically not seen. We're discharging them. So these are patients who have newly diagnosed diabetic or they've got no real issues with their feet. We're trying to ask not to actually refer these patients because we're not going to see them, and often we give them advice of the services available such as Age Concern or Good Neighbour Scheme. The Good Neighbour Scheme I know is up and running. I'm not quite sure about the Age Concern yet. In terms of the moderate risk on here, it's wrong. They're automatically given an appointment every 3 to 6 months. Now that's changed. It's really according to need. Every patient that comes in now that's referred in now will get will get a telephone call, and they will be seen within 2 weeks, and they'll just be monitored, and they can ring in whenever they need an appointment. In terms of the high-risk patients, they're seen what we used to do is see them within 2 months according to the NICE guidelines. But what we've found is that a lot of the patients don't need that. Some people haven't been seen for 6 months without any issues. So again, what we're doing is ringing them up every month, and we're appointing accordingly. We're trying to do as less face-to-face as possible. We are going back to clinics next week. So really it will be back to business as usual in terms of the tier 3 clinics, but we will be seeing less patients in terms of cleaning in between each patient. And also there'll be a lot of patients who need home visits or who don't want to come to clinic because of the COVID, and we'll be doing, I imagine, a lot more home visits than we used to be doing. And most of our consultations will still be actually telephone consultations. We're just seeing according to need. And whereas I was seeing all the ulcer patients, all my colleagues will be seeing them again, because I'll be seeing less patients. And let's say we've got 60 ulcer patients at present. So, I can't possibly see them all in a week. So going on to the next slide. This is just showing you what the pathway is. If you get the electronic referral, then the Barnet appointments triage it onto a waiting list, and my colleagues will triage this patient within 24 hours. If it's an ingrown toenail, and it's my colleague Mark will assess them within 24 hours, telephone assessment, and if they're urgent, book him quite soon for nail surgery. This is actually better than it used to be, because often there was a long list of it was quite a waiting time for nail surgery. It's really putting those urgent ones first, and the non-urgent ones can wait a little bit. What happens with the non-urgent ones, they're seen they're seen within 2 weeks and booked accordingly or not, according to if they need it or not. In terms of high priority, an email is sent to myself, and I ring those patients within 24 hours. If they're usually seen that week. And then seen weekly until they've healed. Once they've healed, they're put on a tier 3 waiting list. So this waiting list, we all ring patients from this waiting list, and they're rung every month to check how they're doing, and if they need an appointment. We also have an email that people can send in pictures to. We've not quite started Blue Jeans yet, but we will be doing, I'm sure, in the near future. So any issues with the patient, they're given a face-to-face appointment. Anything not healing, they will be given, they were not healing for quite a while, or it's got worse, we'll step up to tier 4. Sometimes we do get wrong referrals, infected, necrotic Charcot. We don't ring the patients, we don't ring the patients, we send it immediately to transfer immediately to tier 4. And those who are low risk, they get a telephone assessment within a couple of weeks, and some often advice and discharged accordingly. Moderate risk, they'll be usually seen within 2 weeks, and telephone assessed within 24 hours. And either they're a tier 2 or tier 3. If they're tier 3, they're putting on the waiting list. Try to make it as short as possible, but really, if there's any questions, please ask.
Thank you so much. Thanks a lot. That was really helpful. It's really good to hear about, to have a reminder of the tier system and hear about your urgent services. So thanks so much for that. Any other questions for the diabetes team, please just post it in the chat. In the interest of time, though, I will now hand over to Yogesh Bhatt, who is an ENT consultant from the Royal Free. Thanks, Yogesh.
Thanks, Anisha. Can you hear me?
Yes, I can hear you.
Fantastic. So yeah, just a few slides and then open for questions. So just to let you guys know what ENT was doing during COVID and the surge, we shut all our clinics except for the 2-week head and neck cancer clinics, which all shifted into Chase Farm. So referrals are still coming in Barnet, Chase, CCGs and elsewheres, but all being seen at Chase because we had no clinic space at Barnet. The first tier on call pulled into a medical COVID rota, so our regs were stepping down as SHOs, and we as consultants were stepping down into the red rota. We answered the call of the Royal Free, and undertook a tracheostomy service for the Royal Free, along with the North Middlesex and Barnet. That's 6 consultants for 3 ITUs. And it was busy. Now, when the COVID rota stopped, we got our registrars back and we were able to distribute clinics more effectively. If we move on to the next slide. Yeah, so that's what we did before. If we go to the one prior, sorry. Yeah, super. So, okay.
Yeah, okay. Sorry, there's somebody on the line somebody's not muted and we can hear your phone call. Is it possible to go on mute, everyone? Just check whether you're on mute because there's background noise making it hard to hear. Thanks, Yogesh.
Okay. So, yeah, so if we advance one slide. Yeah, so that's what we do. That's what we used to do in outpatients. It's a really quick and easy thing. Fiber optic nasal endoscopy, oftentimes for patients with pharyngeal symptoms. If we advance now. Great. So that's us during the surge. I mean, I don't know who that is. That's a stock image, but point taken. We're in FFP3s and tracheostomizing across NCL. And so if you move on one now. Great. So this is what clinic looks like for us now. This is clinic. It's a simple outpatient clinic. In order to perform an ENT examination, a pharyngeal exam, we're properly donning, and we're not eyeballing down a scope. We're using stack systems, which we've recently purchased. So everything's different and everything's going to take longer, and constantly capacity for face-to-face assessments at least will shift. Now, we carried on delivering 2-weight services during COVID. We have adopted the same policy that's been adopted nationwide for ENT, which is to use a risk calculator that's been produced by ENT UK to try to determine which patients would benefit from face-to-face assessments, which would benefit from targeted imaging before we see them or otherwise. So that's the greatest shift in head neck diagnostic practice. And you may be aware or not, that Barnet Chase Farm sees 2/3 of the head neck diagnostics in NCL. ECH will see 1/3, and Barnet Chase sees 2/3. So we've got a heavy burden. I should also add that the 2-week referrals have gone back up to pre-COVID baselines. It's gone up to 100 a week again. So what things might, well, there were 2 things that I was asked to talk about. One thing I was asked to talk about in particular, anosmia, and the second is earwax. So with regards to anosmia, Claire Hopkins wrote to various people highlighting the possible link between anosmia and COVID. It's now accepted as a possible symptom. What do we know about anosmia consequent to COVID? Not a huge amount because we don't have any follow-up data. But if we extrapolate against viral anosmia, we would say that 90% of people's anosmia resolves within a month. That's very reassuring. Longer term, most anosmia will get better and can continue to get better if it hasn't within the first month, up to a year and a half. Now, there will be a significant number of people with long-standing anosmia as a consequence of COVID, and the question is what to do. So, if the anosmia has been for more than a fortnight, you could consider nasal steroid therapy, maybe, if you wish. The paper that Claire Hopkins wrote and published in the BMJ talks about waiting a month. What they ask to avoid is oral steroids. This was at a time when we thought that oral steroids would jeopardize the health of patients. But looking at the recovery trial now, it seems like dexamethasone is one of the few things that improves recovery for the sickest of patients. In any event, we're not advocating oral steroids, it's more topical therapy. Question, when to refer? Claire's position is refer if it's been longer than 3 months they have anosmia. And I imagine there's going to be a lot of people out there. And why refer? There's nothing unique that we'll be offering apart from the opportunity to have an MR scan of brain. So the question really is, are we doing it? And we're doing it in part, I guess, for medical legal reasons. I don't think that these patients are any more likely to have an olfactory neuroblastoma than anyone else. So if more than 3 months, the important thing is to signpost them towards the appropriate support. So if we go back one slide, sorry. Yeah. So Fifth Sense and Absence are patient support charities for patients who have lost their sense of smell. Safety advice, of course, is smoke alarms in the house. Make sure you check the expiry dates of food and drink. Reassure them it will get better. hopefully it gets better. As it gets better, they have distorted sense of smell. We call it parosmia or even cacosmia. So if you advance one slide to earwax, yeah. So I received 2 letters by the chief exec actually of patients who were unhappy that they weren't having their earwax tended to during the pandemic. The challenge here is that the outpatient resources are limited, and the rooms that we need to use are aerosol generating procedure rooms, and there is a substantial downtime between successive patients. And the question then is, which patients might we be prioritizing? Well, head neck cancer, certainly. On the other hand, patients who present to us with earwax might be in an at-risk population. So if you consider adults over the age of 70 are more likely to become seriously unwell if they contract COVID, the drive really has to be trying to encourage those patients to receive treatment outside the hospital setting. So my understanding is that there may well be now community, I know there was a community ENT contract that was up to tender and then has changed over a couple of times in the past 4 years, but I believe there is again a community ENT service for wax removal. But I am cautious to sort of advise elderly patients with wax to be frequenting a sort of mixed site hospital, as Barnet is, to have their ears cleaned out. Otherwise, wax softening ear drops sodium bicarbonate are effective. I'm not sure what the general consensus is about syringing. I mean, personally, I don't think it is a dangerous thing if used appropriately. Okay, if we move to the next slide. Yeah, so just a quick mention on 2-week referrals. We are still accepting 2-week referrals. We accept it's very challenging if you might refer without physically examining a patient. Oftentimes we make decisions at this point in time based on their risk of malignancy. So there was a large paper published a year and a half ago by a group up in Newcastle that produced a risk calculator on the likelihood of malignancy in any given patient. We use that to help us establish who might benefit from further assessment. In terms of diagnostics, EUAs are trickier to come by because theatre access is trickier to come by. Head neck cancer resections went down to Princess Grace Hospital via the NCL hub. So my strong feeling is if patients have symptoms that are in keeping with 2-week wait guidance, do refer. Don't defer, do refer. We were in 2 minds as to whether we should just hold on as a group, but it's quite obvious that COVID's not going away, and consequently you shouldn't be holding back. I encourage you to refer as you see fit. Next slide. Yeah, so I guess this was something about thyroid nodules and thyroid lumps. So thyroid cancer surgery is my special interest. The UK head neck radiology guidelines, as suggested by the British Society of Head Neck Imaging, suggested a cessation of thyroid FNA during the surge. Challenge is it's not always possible to know by palpation which is an aggressive cancer and what not. Prior to all services closing, the last case I undertook prior to the lockdown at Barnet was a patient with poorly differentiated thyroid cancer, and you really can't tell simply by palpation. The next few slides are just a reference to when we should be ultrasounding, if we could advance one. Yeah, so just to say that there is an epidemic of differentiated thyroid cancer. It's mostly papillary thyroid cancer. If we advance a slide. Most of these are under 2 centimetres. A lot of them are under 1 centimetre. The vast majority, we think, will probably not cause any problem for a patient if you didn't detect it. The mortality rate has not changed. And the strong feeling is there is a quote-unquote overdiagnosis of small volume thyroid cancer. The challenge for any given clinician is that we can't tell the person sitting in front of us whether theirs will grow or not grow. Arguably, it may be better not to know whether your patient has an 8 millimetre papillary thyroid cancer that would not progress over a 10-year period. If you advance a slide. Yeah, so this is just to say that our ability to identify nodules is proportionate to our use of ultrasound and age. The older the patient, the more likely they are to have nodules. We don't consider it a pathology. It's part of the sort of natural architecture of a thyroid gland. So to have a nodule should not be cause of concern, and certainly you should then have them assessed by an expert, and the expert I would suggest is a hospital radiologist. If we advance a slide. Super. So yeah, lots of different ways of stratifying nodules, and best done in the hands of a head and neck radiologist if we advance a slide. And this is what ends up happening once the needle goes in. Lots of possible permutations and combinations, and it is somewhat involved. But all this starts, of course, with a neck ultrasound. If we advance a slide. So, and if we advance one more. Yeah, so I mean, the general advice for this part of the talk is that there are certain things that do not benefit from having a neck ultrasound, or certainly not a thyroid ultrasound. So overactive thyroid gland and underactive thyroid gland does not need a neck ultrasound. A sensation of a lump in the neck without a palpable mass is likely globus pharyngeus and wouldn't benefit from an ultrasound. If a patient's been assessed by an experienced radiologist and the determination is they have a benign thyroid nodule, unless there is a rapid change in the size of their lump, I would suggest they do not need a follow-up ultrasound scan. And this is that there will be a formal guidance published by NICE. We thought it was going to be June 2021 on the management of thyroid cancer. NICE hasn't produced anything yet, but just to say that neck ultrasound, for the right reasons, is a fantastic resource. It is has the potential to cause real challenges for patients once we know that they have small volume nodal thyroid nodules that then require investigation. I spent the past 3 years at Barnet performing neck ultrasounds. I've got 1,000 on my belt. And we've got a very interesting paper to present, actually, really more for the benefit of primary care than it is for radiology, in terms of what we're scanning for and how we might change guidance in terms of what to scan for and what not to scan for. And if we advance one. Okay, that's the end of the talk. I'm happy to answer any questions.
Brilliant. Thanks so much, Yogesh. It was really helpful to hear about. It was good to hear that the 2-week waits are back up to baseline, and to hear about your risk calculators and your tips about nasal steroids and neck ultrasound. So thanks so much for that. Yogesh, if you can flip into the chat, but I'll tell you what the questions are. So our first question is from Karen Landy, one of our practice nurses, and she says, is it okay to carry out microsuction in GP practices where we have less footfall at the moment and patients are often quite desperate?
Yeah, I think if you have someone who's appropriately trained, it wouldn't be unreasonable to perform microsuction. So one of the questions is, do we consider microsuction to be an aerosol generating procedure? We don't, unless they cough. You might suggest that patients self-isolate for a period of time before they have that microsuction. Or some suggestion of fans being turned on in the background in clinics to blow the air away, but ENT UK guidance suggests not to use any fans, just use a well-ventilated room, ask the patient to wear a mask, you yourself wear a mask, and use the same precautions that you might for any other face-to-face consultation. Preferably, if it's an elective intervention, self-isolate a fortnight prior.
Mm-hmm. Okay, lovely. Thank you so much. And then Vidya Patel, she has a question about home visiting services that ENT offer, because she talks about with the new DES, we're required to do ward rounds within nursing homes and residential homes, and a lot of the patients are bedbound with mobility issues. And is there a hearing assessment service for those patients?
Yeah, it's a fantastic question. So audiology services were not given the green light to reopen. Adult ones weren't given the green light to open from a sort of government perspective almost. And so the real struggle is for ourselves inside the hospital to get audiology reopened. I'm not sure if there is actually an NHS offering of community audiology.
Yeah.
I mean, there are private options in the community, Specsavers and the like, but to my knowledge, I don't believe there is a sort of mobile audiology service presently.
Okay. All right. Thanks for that. A message from Anut Patel. He is asking about management of nasal fracture. Is there a service for this currently? Anup, I don't know whether you want to unmute and explain about your patient. Otherwise, I'm happy to read it out. Would you like to unmute, Anup, or shall I just read it out? I'm not hearing anything. I'll just read it out. Okay, so Anup says, I have had a patient seen at the Royal Free A&E with possible nasal fracture, sent to the Royal Free ENT to assess as may need MUA. Patient sent back to us saying referral to local ENT service, which is Royal Free for us, where she initially went for this, as they did not provide this at the Royal Free ENT because of COVID. Very upset patient, is now going around in circles. So basically, where do we refer nasal fractures, I think? Where's the best service?
So I guess two things, and this is really interesting, really important for everyone to understand. There are 20 ENT consultants in our sector, 6 of which exist in my department. The Royal Free's ENT department, Royal Free Hospital's ENT on-call service, is currently being managed by the Royal National Throat, Nose and Ear. If a patient pitches up to the Royal Free Hospital and they need acute review and or assessment thereafter, they will go down to Huntley Street and UCLH. So until whatever time the Royal National end up leaving, and it might be sooner than later, that is an issue that has to be managed by our colleagues down at UCLH. From our perspective, up in Barnet, at the very start of the surge, we had guidance saying, please do not perform MUA. It's not life-saving. It is highly risky. Don't do it. I think we have now relaxed, actually. So we would say, yeah, do refer them on. But, you know, also be mindful if a patient had an injury a fortnight ago, you're unlikely to, you know, there is a degree of sort of callus formation that sets in. The longer you leave it, the less likely you are to get benefits. And of course, this is all for you know, soft functional indications. So they are still patients using an acute hospital resource come the winter months. You know, you might not consider it wholly appropriate. That said, there is potential consequence of having a fractured nose, which is sometimes functional, oftentimes cosmetic. So for now, whilst we're not surging, I would say refer them down to ED as you had before. And the ED that I'm talking of for us is the Barnet ED.
Okay. All right, lovely. Thank you. I hope that was helpful, Annette. Just a couple of comments from Nick Deshani. He says our audiology provider is restarting microsuction, excluding those with perforated eardrums from the 17th of August, and home visits will also restart, but we're focusing on clearing the COVID backlog. Okay, Nick, maybe you could put the referral details for that in the chat. If Vidya or anybody else wants to make a referral for a home visit, that would be useful. Yeah, next question. All services are reopening in August. David has David Rubin has kindly posted some notes about anosmia, so thanks so much for that. So people can pick his document out from the chat if that would be useful. So thanks so much. No worries, and no problem. So Clara says, is the waiting time for urgent and routine? What is the waiting time for urgent and routine appointments at the moment?
Yeah, that's a great question. So let's just take Barnet in isolation. So the entirety of our Chase Farm offering has been turned over to 2-week wait. Everything is 2-week wait. We're running clinics morning and afternoon, 5 days a week, and in the evenings on Thursdays and Mondays. That's just to manage the 2-week wait demand. So Barnet is the only place that is doing non-2-week wait. The Barnet outpatient service at the moment is required to manage the ED patients. So it is what we call it's a COVID risk managed area. So unfortunately for now, we can't see in a face-to-face capacity elective patients that are non-cancer at Barnet. And so there is, you know, we're engaged.
We're only allowed to do receptionists.
Yeah, I'm sorry. Okay. Sorry. Okay. I'm on a call, but thank you very much.
But you know, if you're here, you can't go back into the main hospital from here.
No, stay there.
Anybody who's come into urgent care.
You okay, Yogesh?
Okay.
Yeah.
Sorry, I have been told. Okay, so to be chastised by receptionist. Okay, so sorry, what were we talking about? We're talking about Barnet's offering.
Yeah, Barnet's outpatients.
Yeah, it is significantly constrained, and we've been speaking with Director of Operations, we've been speaking with Estates, we've been speaking to IPC to get things opened up. So at this point in time, I can't tell you. I think we're looking now at potentially using outpatient resources at the King's Oak. That's in Enfield to start seeing patients. So the Royal Freeze outpatient clinic, which we also run, is more likely to open in the near future. And by that, I mean, we're probably within a fortnight or so. But the Barnet service, that's less clear. I guess the other thing we've not talked about, which we really should, is paediatrics. You guys may well be aware that there's just a massive restructuring of what's open. So at this point in time, to my knowledge, there is not a paediatric service at Barnet. The paediatric ED isn't open, paediatric ward isn't open. North Mid reopened their service, and so unfortunately we can't accept the patients like we could accept in the past. Yeah. So yeah, it's a challenge. I guess the information, I guess, really comes from once the ward opens, then we're able to do more. Clinics, as you know, didn't really, clinics shifted over from Barnet into Chase Farm. I think it was about 2 years ago, wasn't it, when the new Chase Farm opened? So yeah, once we know more information, we can let you guys know. But you know, this is something that's really out of our, it's not in our gift. It's
yeah, no, we understand it's
items driven by the CAG, and yeah, it's very challenging.
Yeah, sure. I think we're due an update on paediatric reopening at Barnet soon. But yeah, we understand there's obviously huge pressures on the service. We'll move on to Sanju's question, which is, given COVID and virtual first in primary care, are there any clinical history tips that could assist in directing patients, e.g. direct ultrasound, physical assessment or referral?
Yeah, and that's related to thyroid assessment, you say? Sorry, could you repeat the question?
All right. So he said, are there any tips? I think he means to do with the history when we're assessing patients virtually, and then how we direct them basically to direct ultrasound or for physical assessment. Yeah. So are they? Yeah.
For thyroid, yes.
Yeah, I think for the most part, if you have a patient who has a long-standing mass without rapid change and without risk factors, you could argue that it's unlikely that this will be a clinically significant lesion that will change or, you know, impact the patient. I guess the unfortunate truth is that it's sometimes just not possible to know unless you've had a high resolution scan. So I guess put another way, the question might be, what would you not be assessing for? I think that's probably an easier way to consider it. So we perhaps would not be assessing for patients with symmetrical long-standing goiter. We would not be assessing for patients who have an overactive gland. We would not be assessing for patients whose only presentation factor would be that they have an underactive gland. So asymmetrical nodularity that's palpable, I think that's important to assess. Incidental findings, again, we tend to say that it's based on clinical suspicion. But again, what are the risk factors that we talk of? The risk factors are radiation, external beam radiation. That's unlikely that a patient's had external beam radiation. Long-standing iodine deficiency. This is epidemiological. It's unlikely in this country. So the truth is there aren't many risk factors to put your hat on, really. I guess that the more important thing would be, I guess there are two things perhaps. One is try to not request scans that might throw up incidental findings. And then when you are assessing scans, or requesting scans rather, aim to have them performed by radiologists who are sort of confident in their ability to identify risk. So we saw, I don't know if you caught one of the slides at the beginning of the talk about, there was a pictogram effectively of different sorts of nodules. And what we know is that if you have less experience, you may be more inclined to call something U3. Now, the truth is that the malignancy rate in a U3 nodule is actually incredibly low. It might be something like 5 to at most 10%. I think that's low. But if you call it E3, what it also means is that this might benefit from needle assessment. And the moment you start that journey, it means referral via 2-week wait, needle assessment. If it comes back as Stye 1, we repeat it, then we repeat it again. So you might have more than a couple. If the cytologist's feeling is that actually something looks unusual on cytology, then again, you might be pushing someone, walking someone slightly towards having half the gland removed.
Okay. Thanks, Yash, that's helpful. And then I think just in the interest of time, we'll just take 2 more questions. First is from David Rubin, who asked about recurrent epistaxis, having tried and he, you know, if you need to consider cauterization, where would you refer? Would that be Barnet? Hello, Yogesh? Are you still there? Okay, I think we seem to have lost Yogesh, but hopefully he'll try and log back in again. While we're waiting for him, should we go back to David Rubin's question for the CCG and Federation? David, I don't know whether you want to unmute because it was quite a long comment in the box, but it's basically about the flu program and issues around delivering it outside or inside. Do you want to expand, David?
So yes, at our weekly webinar by our leads for the our PCN, who's on the board of the CCG, he was saying that, and this was verbal, that there's discussion at the CCG about the fact about how flu programs might be given there's some emerging evidence that COVID might be airborne and therefore hangs around for 4 to 6 hours, and therefore it might not be safe even to consider doing flus in large gyms, let alone as walkthroughs through practices. And that would suggest therefore practice should be doing it perhaps outside, either in cars or sort of setting up gazebos, which is all well and good, except we've got a concrete pavement outside and we can't sort of pin that down into the ground anyway and it'll blow away. And you need more than one gazebo to allow patients to take their coats off and put their coats on again either side. So I was wondering if there's anything more formal about that, and possibly whether that would suggest something along the lines of an open air marquee, which after all must be going for a bargain at the moment, given there's no large weddings happening at the moment, and the marquee suppliers must be looking for cheap deals, and perhaps set that up on some public ground somewhere, and then perhaps get each practice a nominated half day to then en masse vaccinate, and you have 4 doctors, 3 nurses, and a sort of 7-line lineup, 7 lines, and patients walking up. And I don't know whether you could vaccinate at say 30-second intervals.
Yeah, thanks, David.
Anisha, I'm happy to come in. Thanks, David, for flagging some of those issues. There's an NHSEI letter, a second letter that's due to come out imminently for flu, which is hopefully going to have a lot more national guidance. This is being worked up across with NCL CCGs, with borough teams, the primary care networks as well. So nothing's formalised yet. The conversations and discussions are still happening. And there are, as you can imagine, you've made lots of very interesting suggestions, but there are lots and lots of different questions like, does indemnity cover if you're doing things off site? There's lots of complexities to lots of different issues. And probably what the aim is for the system to get as many people vaccinated, and we know we do pretty well. We hit the 75% target for those who are elderly. We don't normally come anywhere near close for our groups of patients who are at risk, and those are the ones we're looking really to boost. So what the CCG is going to do is an LCS, a locally commissioned service, and what we're looking to is just go through the nuts and bolts of how that's most effective. So how, because we know there might be issues with getting supplies into individual practices. There's so many different parts to the system that are tricky. We're just trying to make it as effective and as fair as possible, but there will be extra remuneration with it, and probably it will be a mixture of stuff happening at individual practice level and also stuff happening at PCN level. So that's probably what's going to happen, but this is still being worked up, but it needs to be worked up quickly, obviously, because we're aware that the solutions need to be fixed before the end of August. But thanks for flagging some of those, and a lot of those issues are being discussed and worked up. So I hope that that's helpful. And on the call tomorrow, I'm chairing the webinar tomorrow, Joe's webinar, and actually the main part of it's going to be on flu. So anybody who wants to join that will hear an update.
Brilliant. Thank you, Charlotte. I don't know whether we've got Yogesh back again. But I wonder whether, in the interest of time, we should be wrapping up anyway. Yogesh, are you back?
Yeah, I'm back. Yeah.
Oh, brilliant. Thanks for that. I mean, we are running over. So, Yogesh, is it okay if I perhaps email you the other? I think there are a couple of questions that we haven't addressed. Yeah, and then I can come back to the group.
Sure. Yeah, sounds good.
Brilliant. Thanks so much, and thanks so much for your really helpful talk. It was very relevant to primary care and relevant to what's going on at the moment. So thanks so much for joining us and giving up your time.
Pleasure. Thanks very much, Nisha.
Thanks.
Cheers.
So just in wrapping up, I'll echo the thank you to Yogesh. I think it's really challenging. You did really well keeping your cool, even though you were obviously made to move. So thank you very much. And it's really difficult to hear how hard it is for secondary care clinicians in trying to work out how services are being restarted, and really empathise with you. And we're finding it hard in primary care and aware that you guys are also finding it hard in secondary care. We're just fortunate in Barnet that we've got a provision of a community provider. And as Nick said in the chat, that a lot of this is going to be actually going to be restarted, and I think the 17th is one of the dates that Nick gave, and that includes domiciliary visiting for audiology, so that's really helpful. But really hope that the wider services are sorted out as soon as possible. Thank you also to Soraya and to Orna for the update about diabetes, and for all of you letting us know what's been happening within the surge of the pandemic, and actually what's happening now as we're passing surge, getting into the news, into trying to get to business as usual. And most of you will know that there was a letter that came out from NHS England at the end of the week, which gave targets for the SIS for secondary care, which is saying that by end of August, September time, getting to 90% of previous activity, and by September, October time being at 100%. Certainly this is going to drive a tremendous change in the activity level going to be seen in secondary care. We've got a gap next week, but we've got 2 weeks' time, and we're going to have Devon Patel, the cardiologist from Barnet. He's going to be talking about breathless patients, heart failure, and tips on how to interpret BNP and echo. And then the one after that, your request is on mental health. So if you're still online, and there's 47 people still on, if you could just post any topics that you want to cover about mental health. And then looking at feedback again, we've been looking at how often people come to the meetings, and we get the sense of that the ask is now to step back to doing them monthly rather than 2 weekly, and that will be reducing in October time. So if you could just post on any thoughts about mental health, or otherwise email Anisha or me, that would be really helpful. And just thank you to everybody, and hope that you have a lovely afternoon, and hope that we all get a chance to have a break over August before we come back and to regroup in towards the end of August. So hope you get to have a break, and hope the English weather's good. Many thanks, and have a good afternoon.
Thank you very much, everyone.